Good afternoon. I would like to thank Professor El Ghazali for the kind invitation. My role today is to discuss the emerging evidence on the role of CDK4/6 inhibitors in early breast cancer. Please find here my disclosures. So this is the outline of my presentation, and let me start with a little background. Indeed, it is important to remind that there is a significant proportion of hormone receptor positive, HER2 negative early breast cancer patients who relapse despite having received optimal adjuvant therapy. And the stage is, of course, one of the main determinants of the risk of relapse. Here are data from more than 60,000 patients who were disease-free after 5 years of adjuvant endocrine therapy. And you can see that the breast cancer recurrences continue steadily through the study period from 5 years to 20 years, and is strongly correlated with the original T and N status. Here are mortality data from the SEER database showing that in patients with hormone receptor positive HER2 negative breast cancer, there is a higher mortality rates in case of four or more positive nodes, tumor grade 3, and greater tumor size. And when looking at data from trials evaluating the role of gene expression profiles such as the MINDACT and the TAILOR-X study, which included predominantly a node-negative population, you can see that despite the use of chemoendocrine therapy, high-risk patients still present a significant risk of relapse. So it is clear that a proportion of hormone receptor positive early breast cancer requires additional therapy. And in the past few years, we have faced the advent of CDK4/6 inhibitors in the metastatic setting. This strategy has been progressively evaluated in early disease, starting from the trials in the neoadjuvant setting. Here is just a summary of the evidence that set the CDK4/6 inhibitors in combination with hormonal therapy as new standard for the treatment of hormone receptor positive, HER2 negative metastatic breast cancer. Here is just a summary of the data evaluating CDK4/6 inhibitors in combination with aromatase inhibitors as first line of therapy. And you can see very clinically meaningful and consistent results in terms of progression-free survival advantage, with also the OS advantage from the Mona Lisa 7 conducted in premenopausal population. Here are data of CDK4/6 inhibitors in combination with fulvestrant in patients with endocrine resistant advanced breast cancer. Again, very important results in terms of progression-free survival and also overall survival. So clearly showing that this strategy has an important impact on the natural history of the disease. And so on the basis of these really striking data, of course, the combination of CDK4/6 inhibitors and hormonal therapy results particularly appealing to be tested in the early disease setting. And here is just a summary of some of the neoadjuvant trials, mainly randomized phase 2 trial, evaluating this combination in the context of early breast cancer. And you can see that in the majority of the cases, these trials have biological primary endpoint. I will report more in detail the results of the Neo-Monarch trial, as previously mentioned, a phase 2 neoadjuvant trial conducted in approximately 300 patients. And here you can see that Abema, a single agent or in combination with anastrozole, was able to induce a higher Ki-67 decrease as compared to anastrozole, confirming, of course, the potency of the combination, but also the activity of the Abema as single agent, and also the combination resulted in a more potent, more profound cell cycle arrest after 2 weeks of treatment exposure, as summarized here. And also there are very interesting data regarding the role of the combination of abema plus anastrozole in enhancing the adaptive immune response markers, as shown here. So now move to the evidence derived from the randomized trials in the adjuvant setting, starting of course from the Monarch E trial. The results of the Monarch E trial were presented at the last ESMO meeting with the simultaneous publication on JCO. This is the Monarch E study design. In particular, to be eligible for the study, patients have to have 4 or more positive axillary nodes, or from 1 to 3 positive axillary nodes, and or tumor size equal or greater than 5 centimeters, or histologic grade 3, or Ki67 higher than 20% per central evaluation. More than 5,600 patients were randomized to receive abema for 2 years in combination with the standard of care endocrine therapy, meaning from 5 to 10 years of endocrine therapy as per clinical indication versus standard of care endocrine therapy alone. The primary endpoint was the invasive disease-free survival. This is the statistical plan of the Monarch E trial. As shown here, the study was powered assuming a hazard ratio of 0.73 for invasive disease-free survival, requiring approximately 390 invasive disease-free survival events for the primary analysis. The study met the primary endpoint at the second interim analysis, which was performed on approximately 80% of the total IDFS events required. Here is a summary describing the key patient's characteristics. As shown here, you can see that approximately 95 of the patients have received adjuvant or neoadjuvant chemotherapy, so reflecting the selection of a high-risk population. And as shown here, approximately 60% of the patients have 4 or more positive axillary lymph nodes. And here is the details of patients with the 1 to 3 positive nodes. And here is the primary endpoint. The data matured at a median follow-up of 15.5 months. And as shown here, the combination of abemaciclib plus hormonal therapy was associated with a significant prolongation of invasive disease-free survival. The hazard ratio is 0.747, corresponding to a relative risk of invasive disease reduced by more than 25%. When looking at the rates of invasive disease-free survival at 2 years, you can see an absolute difference of 3.5% favoring the combination. It is important to remind that the majority of the invasive disease-free survival events were distant events. And here is the report of the distant relapse-free survival. Again, a significant prolongation for the combination, another ratio of 0.717 with a relative risk of distant recurrence, which is reduced by 28.3%, and an absolute difference at 2 years of 3.3%. Here is just a summary of the treatment emergent adverse events. The safety profile is reported in the Monarch E trial is consistent with the already well characterized safety profile of abemaciclib described in trials conducted in the metastatic setting. At the last San Antonio meeting, the results of the final analysis on the whole number of events have been presented. So this is the invasive disease-free survival at the primary outcome analysis with the median follow-up of 19.1 months. The results are very consistent from those of the interim analysis presented at ESMO. So a significant reduction of invasive disease-free survival events as a ratio 0.73, so corresponding to a reduction in the risk of developing an invasive disease-free survival event of more than 28%. The palbociclib have been also evaluated in the adjuvant setting, unfortunately with the negative results. This is the study design of the Pallas trial, where patients were randomized to receive palbociclib for 2 years in combination with endocrine treatment as compared to endocrine treatment alone. You can see a similar sample size as compared to the Monarch trial, more than 5,600 patients. Here are the main eligibility criteria, so stage 2 to 3, as well as completion of prior surgery or chemo and when indicated, and the radiation therapy. Here are summarized the stratification factors, and similarly to the Monarch E trial, the primary endpoint was the invasive disease-free survival. Here is just summary of the main baseline patients' characteristics as shown here. There are more than 30% of patients with stage 2B and 48 to stage 3, so pretty high risk population. In particular, we have more than 58% of the patients with the 4 or more positive nodes, or from 1 to 3 positive nodes, and either stage T3, T4, and or grade 3 disease. And more than 80% of the patients have also received the prior chemotherapy. And here are summarized the results in terms of invasive disease-free survival and distant relapse-free survival. In the Pallas trial, the follow-up is a little bit longer than that observed matured in the Monarch E trial. Here is more than 23 months. And you can see absolutely no differences in terms of invasive disease-free survival we have another ratio of 0.93 for invasive disease-free survival, and again, absolutely no difference in terms of distant relapse-free survival with another ratio of 1. Palbociclib has also been evaluated in the Penelope B trial. The Penelope B trial is a very interesting trial evaluating the role of palbo in combination with hormonal therapy as post-neoadjuvant treatment. In this trial, patients were selected for having high risk of relapse according to the residual disease after the exposure to neoadjuvant chemotherapy followed by surgery. In the Penelope B trial, palbo was administered for 1 year in combination with standard endocrine therapy, and in the control arm, patients received placebo plus standard endocrine therapy. The results of the Penelope B trial were presented at the last San Antonio meeting. Here are summarized the main baseline patients' characteristics, including the residual disease after neoadjuvant chemotherapy. So we can say that this is a particular high-risk population. And here are the results of the primary endpoint, the invasive disease-free survival, as well as the interim analysis for for overall survival. And again, no, the trial is negative with no difference in terms of invasive disease-free survival for palbo plus standard endocrine therapy over endocrine therapy alone. It is important to remind that this is the trial with the longest follow-up so far. The median follow-up is 42.8 months. And here is just a summary of the evidence that we have so far of CDK4/6 inhibitors in combination with hormonal therapy in hormone receptor positive, HER2 negative early breast cancer, with the main findings summarized here. So just a mention on the problem of treatment discontinuation in the PALLAS trial. It has been hypothesized that the negative results might have been due to the high discontinuation rate due to adverse events observed in the PALLAS trial, which was 27%, but these data are not consistent with the observation in Penelope trial, which is a negative trial with a very low discontinuation rate due to adverse events. Just a mention on the ongoing Natalie trial. The Natalie trial is evaluating ribociclib 400 milligrams in combination with the endocrine therapy versus endocrine therapy. This trial is ongoing, so we have no information on the patient population enrolled. We know from the inclusion criteria that they are selecting stage 2-3 early breast cancer patients, and it is important in this case the ribo is administered for 3 years. So in conclusion, the Monarch E has formally established the superiority of abemaciclib in combination with the hormonal therapy as compared to hormonal therapy alone in a population of high-risk early breast cancer patients. Of course, the follow-up is quite short considering the population of hormone receptor positive patients. So further follow-up is of course needed to confirm abema as a standard component of adjuvant therapy. We have negative results with palbociclib so far. Maybe we can consider that the peculiarity of abemaciclib, which can be potential advantages, including the continuous daily dosing as compared to the other CDK4/6 inhibitors, the different inhibition of the kinase, the activity as single agent described and demonstrated in the Monarch 1 trial as well as in the Neo-Monarch trial, and of course different safety profile. So these are potential advantages that possibly are more relevant in the early disease setting, given the very similar results that we have in the metastatic setting as compared to the other CDK4/6 inhibitors. Of course, there are some points that need to be still clarified, such as the duration of CDK4/6 inhibition in early breast cancer, the role of CDK4/6 inhibitors versus chemotherapy, and finally, the genomic classifiers for patient selection. Thank you all for your attention.